So I think people really like tools that can help them understand themselves better in an uncertain world, right? So people like to look at their zodiac sign. They like to read their horoscopes. They like to take quizzes on BuzzFeed to kind of figure out what kind of baked potato they are or what Taylor Swift song like perfectly matches their vibe.
Take your Pottermore quiz, right?
Yeah, right. And people love to be validated, right? And so I think that's one reason why just personality tests in general are really popular. Then I think the Myers-Briggs in particular, I think they do a really good job with marketing. So, with their different types and then the names for the different types, right? Like, I think it's really easy for people to kind of see themselves in those traits. And I think that they are pretty face valid, which essentially just means, what you put into them, you get back.
How do young men like us optimize our lives in a way that lets us achieve success and meaning? Come with me as I interview top performers and delve into key areas of life. Habits, finance, psychology, health, relationships, work, creativity, and business. I boil the ocean of men's advice into usable wisdom in this podcast to give you the answers. My name is Blake Bottrell, and this is the Distilled Podcast. My guest today wrote the book on neuroticism, literally. With over 120 publications, she's at the forefront of multidisciplinary therapeutic research aimed at causes, not symptoms. She wants everyone to know that the personality test that you took in high school isn't a prescription for the rest of your life, and that there are steps you can take in and out of therapy to nudge your personality in a better direction. Dr. Sauer-Zavala, welcome to the show.
Thank you so much for having me. I'm really excited to be here.
Why do people love Myers-Briggs assessments despite their sort of lack of efficacy to mean anything?
Yeah, so I think a couple of reasons. So I think people really like tools that can help them understand themselves better in an uncertain world, right? So people like to look at their zodiac sign. They like to read their horoscopes. They like to take quizzes on BuzzFeed to kind of figure out what kind of baked potato they are or what Taylor Swift song like perfectly matches their vibe.
Take your Pottermore quiz, right?
Yeah, right. And people love to be validated, right? So you like to, have the test reflect back to you like, oh, you're a Gryffindor, obviously. And so I think that's one reason why just personality tests in general are really popular. And then I think the Myers-Briggs in particular, I think they do a really good job with marketing. So, with their different types and then the names for the different types, right? Like, I think that it's really easy for people to kind of see themselves in those traits. And I think that they are pretty face valid, which essentially just means, what you put into them, you get back. So when I take a Myers-Briggs test, I'm a protagonist, and I like that. That sounds nice. Unfortunately, most of these like kind of commercially available personality tests, the ones that are used to funnel people into careers, are not really evidence-based. And when they have been tested, they don't predict career success, which is kind of the thing that they're being used for. So it's kind of unfortunate.
Going in the opposite direction then, can you give me sort of a quick rundown on the 5-factor model or the big 5 and then neuroticism in particular, and we'll get into that?
So one of the evidence-based kind of theories of personality is that all the differences across people can be kind of boiled down to 5 kind of overarching traits, like 5 traits to rule them all. And the way that those traits kind of first were found, I guess, was that researchers like kind of in the early 1900s combed over a dictionary and pulled out all of the words that described people. And they tried to kind of group them into as small of categories as they could. And once they got to 5, they really just couldn't reduce it anymore. And as like data analytic tools have gotten more and more sophisticated, we've been able to replicate that 5-factor structure across tons of different cultures and languages. We see it over and over and over again. And so the 5 traits are, you've already kind of teed up neuroticism, which is the tendency to experience negative emotions. That's kind of on a continuum with what we call emotional stability. So just kind of like the people for whom stressors just sort of roll off their back. Then you've got extroversion versus introversion. A lot of people think extroversion is like how sociable you are, and that's part of it. But really kind of the overarching piece of extroversion is your tendency to kind of like be excitable, energetic, and being sociable is kind of part of that. Another one that's really important, particularly for kind of career success associated with like making more money, is conscientiousness versus disinhibition. Conscientiousness is your tendency to be reliable, to be ambitious, to be organized versus like being more spontaneous, maybe not being that great of a planner. Then you've got agreeableness versus antagonism. Agreeableness is like how empathetic you are, how trusting, how kind or tenderhearted on a continuum with, being a little bit more sort of walled off or a little bit more fierce. And then finally, openness to experience, kind of on a continuum with, no surprise, closeness to experience. And it is people that are high in openness are more likely to appreciate like art museums and aesthetics and new ideas. They like to philosophize about things. Whereas people lower on that trait tend to be more traditional, tend to be more conservative.
Is there a typical way that we should look at these continuums of personality traits? Are there, I guess another way of saying that, is there sort of any longitudinal evidence to success or well-being as far as where we should try to nudge our personality traits towards? Are we looking more towards the middle of the bell curve? Is there one spot where we're supposed to be spiky? Is there anything along those?
Well, I think it depends on what you define as success, right? So there really is. So I love this question because there really is no sort of like right level to be on any trait. You have to kind of like work backwards a little bit and think about like what are your values, what's important to you, what do you want to achieve, and that will sort of inform what's going to be useful for you, right? So like if you are hoping to be a kindergarten teacher, right, like being really high in agreeableness and patience, that's going to be like paramount, right? But if you are like, I don't know, like in a managerial position where you have to fire people, like that, you need to kind of cultivate less tenderheartedness if you're starting out that way. So I don't think there's necessarily a right or optimal level. And really there's pros and cons to both poles too, right? So we think about neuroticism as tendency to experience negative emotions. The higher you are in neuroticism, the more likely you are to experience depression and anxiety. I mean, we know that that's true. But you can also imagine that, like, if you're like way low in neuroticism, you might be really stoic. I've had friends tell me that they are kind of low in
I am in the 7th percentile of neuroticism. So there you go.
I'm kind of in the middle to like medium high, but I've had friends that are really low in neuroticism, and they tell me that their wives say that when they come home from work and they're like, this thing happened, that their husbands, my friends, right, are like not validating enough, right? Because they're not getting upset on their wives' behalf. And I think it can be like, I mean, that's like normal low neuroticism. And then like people who like are more like antisocial personality disorder tend to have really low neuroticism because they take risks and get in trouble. So yeah, at first pass, lower neuroticism is better, but definitely there's cons. There's costs to that as well.
Going back to, you talked a little bit about the Myers-Briggs being used as a predictor for career fields, and talking back to Big Five here. Is there anything, you mentioned conscientiousness as far as being a better predictor of career success? If that's a domain that we're looking to potentially maximize, is there something other than conscientiousness that we should be focused on as far as research pointing in that direction?
So definitely conscientiousness is going to be kind of like the biggest predictor of career success. It's a big predictor of health, right? Because people that are conscientious go to the doctor, follow up on things. So that's a big one. And that's one certainly we can circle back to because sort of in my own life, it's a trait that I've developed over time. Like people don't believe me, but when I was in high school, I was extremely lazy and messy. Like I failed math for the year because I didn't go to it, and now I like run a research lab doing clinical trials funded by the government. So a lot happened in those intervening 20 years, I think, that really helped develop that trait. So conscientiousness is a really big one for like work success. But, the more, if you're too high in conscientiousness, you run the risk of being like rigid and, it can kind of stunt creativity. Whereas I think the spontaneity can be really helpful when you're trying to generate new ideas. So I think that's important. Neuroticism, I think, can get in the way depending on what your job is, right? So the example I always give in kind of the career space is like, well, I want to go up for the next promotion, but it's going to require me to talk more in meetings or do give public speaking, right? And that makes me really anxious. I don't want to be the center of attention. And so that anxiety, right, the person might choose to avoid moving forward in their career, and that's going to obviously limit them.
How important is an identity change focus as far as moving some of these? You talk about changing your conscientiousness to be more conscientious. How important is putting identity ahead of the actual changes that you want to see?
Yeah. So I think that well, I'll back up a little bit and say I'm a cognitive behavior therapist, right? That's like kind of my training, and the interventions I develop are CBT interventions. And so I think what we tell ourselves, our perceptions, what we tell ourselves about ourselves, our identity, really important, right? And then our behaviors. Those are kind of the two factors. And it's probably even worth backing up a little bit more to say that the definition of personality is your characteristic way of thinking and behaving, right? So a lot of times we're like, oh, you could never change your personality. But when you think of personality as your characteristic ways of thinking and behaving, we change how we think and behave all the time. And if you do that consistently over time, right, and it becomes kind of habitual, then you've changed your personality. You're going to respond to those personality questions differently. So I think identity is really important. The example that I always give with my clients is and my students too, right? Well, I'm just not a planner. I need the adrenaline of the last minute to pack or to start my paper before it's due, right? That's a belief. It's not a fact, right? You don't literally need adrenaline to open a Word document on your computer. It's just something you're telling yourself, right? And so if you can shift that a little bit and remind yourself, well, yeah, I don't literally need adrenaline. I could actually start beforehand. That might be enough push to then change your behavior.
So I alluded to it a little bit off the top, but you wrote a 300-page book on neuroticism. Can you sort of give us the Coles Notes version of the book and what we need to know to really make sense of neuroticism as it applies to psychopathology?
The big take-home piece is that when we think about common mental health conditions like depression, like anxiety, worry, panic, social anxiety, OCD, eating disorders, borderline personality disorder, I'm kind of listing kind of the common things that people struggle with that bring them to therapy. What we found is that most people don't come to therapy with one problem. They come to therapy with depression and anxiety. They come to therapy with borderline personality disorder and panic disorder and social anxiety disorder. And so researchers have been really interested in what is going on. And it's not that people are just really struggling. It's that all of these different conditions have the same vulnerability, right? So if you're high on the vulnerability, then of course you're going to exhibit symptoms across the same, across different disorders, right? So if, I don't know, having high blood pressure is a risk factor for stroke and heart attack, right? That's why we might see both of those things in the same person if they have high blood pressure, right? So you can think about high neuroticism as sort of something like that could simultaneously lead to symptoms across different disorders. So if we kind of put that on the shelf for a second, the other thing I'm really interested in is simplifying how people get treatment. So when we think about all the different mental health conditions as their own thing, their own specific entity, then of course we're going to want different treatments, a different treatment for panic disorder, a different treatment for generalized anxiety, a different treatment for social anxiety. That's a real pain in the neck for therapists. And it's not great for patients either because, if you have depression and anxiety and the manuals for depression, well, what about your anxiety? So the whole idea, right, is if there are these shared vulnerabilities, isn't it more efficient to target that rather than play whack-a-mole with the different symptoms. So that's the 300-page book in a nutshell.
So then what's the unified protocol?
Yeah, the unified protocol is a treatment that I helped develop when I was at Boston University that is what we call transdiagnostic. It means it applies across diagnostic boundaries. You can use it with all those different disorders that I mentioned, and it targets neuroticism. And what we found is that when we use the unified protocol and we compare it to those like single disorder manuals, one manual for each different disorder, that the unified protocol, or UP, reduces neuroticism more than the other treatments. It's just as good at treating like the main diagnosis as the very specific protocol for that diagnosis, but it's just a lot easier and more efficient.
I don't know if this is a curse of knowledge problem on my part or whether I'm not thinking through something, but surely this can't be a novel idea. Like, surely why has no one tried to treat neuroticism as a whole before versus all these different DSM diagnoses?
This is a question with like a long answer that kind of goes back to like a Hippocrates, right? Basically, people have been kind of noticing differences in temperament, personality for a really long time, going all the way back to the four humors. Basically, like the four humors can kind of, if you squint your eyes a little bit, look like kind of the neuroticism and extroversion continuum. And so people have been interested in this for a really long time. And basically, like, it used to be, I think, like, sort of up through, I don't know, like the mid 1900s, a lot of our treatment in the field of psychology, psychiatry was more like psychodynamic in nature. And it was really interested in like uncovering like the etiology or like where these conditions came from. And there really wasn't great research on that. And so when the DSM was published, the DSM is our kind of like manual of all the different symptoms for all the different disorders. And so when DSM-3 was published in 1980, there was this big push by the person in charge of it to really get away from all the etiology and just describe what we could see. So like when someone's depressed, what we see is that they sleep a lot more or they sleep a lot less. They eat a lot more or they eat a lot less. Sometimes they describe having suicidal thoughts. Sometimes they describe feeling guilty. Sometimes they describe like loss of pleasure, and always they describe low mood. And so really then from 1980, I guess for the next 40 years, we've been really focused on what we can see objectively. And I think that's taken us away. We've really focused on what's different between disorders instead of what they share.
So the danger in neuroticism too, and the small amount of research I've done, sounds that it extends also beyond the psychological realm and also gets into like physiological complications. And yeah. I was wondering if you could like speak a little bit to any of that research, as far as you would think it makes sense for someone who is very neurotic to have multiple comorbidities of mental health diagnosis. But there's also apparently a lot of literature to suggest that there's a higher all-cause mortality for physiological things as well.
Yeah. So neuroticism is like, you can think of it really basically as like tendency to experience negative emotions or stress reactivity. And so I am, much more of like a mental health researcher, but I'm gonna do my best. So basically our like sympathetic nervous system, it's like the physiological system that kicks on when there's threat, right? And like if we're neurotic, we're more likely to detect threat. That system is supposed to like come on when we need it and come off when we, kind of hit the brake when we don't. And when it is, kind of chronically triggered, that's a lot of wear and tear on the body that, really impact physical health. It's probably about as scientific as I can get without having to open my book and read that part.
That's fair. In my short bit of research, stuff popping up about chronic inflammation and higher biomarkers for triggers as far as different proteins and stuff go. So what was there's some popular book, it's called like The Body Keeps the Score or something like that. So there you go. Not quite as foo-foo as some people probably want to make it out to seem. So getting back to this sort of further breakdown within the DSM, I know that there's, like you talked about, there's a lot of comorbidity between diagnosis, and there's a lot of different overlap in terms of what symptoms present as different particular disorders. Have we sort of oversliced the pie a little bit in terms of what is useful for patient care? And the reason I bring that up is because it feels like there's the potential that we've gone so far to make all these diagnoses, but if it doesn't actually solve the problem in trying to make people better by having these individualized styles of care, are we like going backwards in a way?
Yes. So I think that probably the people that specialize in social anxiety would feel differently, right? The people that have really hung their hat on treating panic disorder would feel differently. But for me and the research that I do on transdiagnostic treatments and personality and I practice also the patients that I see, I guess I kind of feel like just because you can differentiate something doesn't mean it's a meaningful difference that we should pay attention to, right? So yeah, like OCD and panic disorder, they present really differently, right? But when you think about like the function of the symptoms, so in panic, right, like I'm afraid I'm going to have a panic attack, and that's so uncomfortable to me. So if I feel a panic attack coming on while I'm in the grocery store, I get out of there, and then my anxiety goes down. OCD, right? I have an intrusive thought and it's so anxiety provoking to me. I hate it. So then I knock on wood and then I get that quick relief, right? So the symptoms look different, but the function of those symptoms, the behaviors is exactly the same. It's to like escape distress. And so what you need is a treatment that like helps people basically get cool with feeling their emotions, because it's the avoidance across all of these conditions that like perpetuates the symptoms. And if you do kind of like a functional assessment of why people are doing what they're doing, and you have a kind of a cursory idea of what's going on, to me and my clinical work, I don't think it matters knowing, exactly what DSM diagnosis they have.
Yeah, and you say, like, going back to the idea that if there's one specific way that a therapist is trying to treat OCD versus a therapist who's trying to treat a panic disorder versus someone who's trying to treat generalized anxiety, like there are different prescribed methods for treating all these things. And because there's so much overlap in the diagnosis, people can feel like they're getting treated for one thing and not another. And then they're coming back 3 years later. And then, so there's all these sort of second order effects of over specifying. And then you get therapists that can't treat as well because they've got to know 17 different disciplines. And again, coming back to if the gold standard is patient care, like, isn't that the thing we should be optimizing for, and not saying you have this manual that says I can treat this thing in 14 sessions or whatever?
Right. And I think to your point, right, that like if you have 17 different treatments that you have to learn and you work in community mental health, and so you have a patient every hour for an 8-hour day at work, like you don't just like provide those manualized treatments, like maybe not that well. You don't provide them at all because there's no time to prep in between sessions and there's no money to train you in most kind of public situations, right? Which is where most people get their care, right? Like there's always going to be people that can afford to pay out of pocket for like really like nice boutique treatment, but that's not most people. And so basically and understandably, like no shade on any therapist that's doing this. It's easy for me to provide evidence-based or like manualized care because I have 4 patients. It's not really my main gig, but a lot of times that's why you get into like what I call how was your week therapy, where it's like, gosh, like I haven't seen you in a couple weeks because my caseload is too full, so I can't even see you weekly, and I don't really kind of remember what we were working on. So like, just tell me how your week was, and then just sort of pull strategies as best you can. I understand it.
Do you think part of it could be an incentive problem? For me, I always try to look at incentives as like a powerful mover
Mhm.
for things. And
Yeah.
I just don't know that from like a governing board of directors point of view, there's a lot of benefit for transdiagnostic therapy, because then you can't treat people for 4 different disorders and it takes them 2 years to get through therapy, and we can charge them $12,000 more or $15,000 more. Is that part of what we could be lining up here? Am I looking too far into things?
Yeah, I don't know. I don't think I'm that cynical. I guess I'll say, like, in terms of like, I don't think people, well, certainly like therapists don't go into business to make a lot of money because we don't. It may seem like we do because it's like expensive to get treated, but like well, you're in Canada, so it's less of this, but like, I mean, insurance companies don't reimburse us very well. So I don't think therapists are like trying to keep people in treatment longer. I mean, I can speak to my government where they are like not so great at thinking about prevention. They're sort of better at thinking about like, oh no, this is a big problem now. But they like kind of hate to spend money.
Western healthcare loves treating symptoms and not causes. So
It's so
yeah,
bad. It's so
yeah.
so I think that's why like public mental health programs like it's harder for therapists to get training. It's hard for them to have time to to prep, to learn, and I think that kind of perpetuates the problem.
Is there anything that you're seeing on the sort of grassroots side in the therapy world that people are sort of coming together to sort of crowdsource some of that, either training or different ideation of things?
Let me think about how I want to answer that. So on the like diagnosis side, I can give a shout out to this consortium called High Top. That's the abbreviation. It's not great marketing. So it stands for Hierarchical Taxonomy of Psychopathology. So I don't know how we're going to really like get that out into the world, but basically it's really about thinking about sort of shared risk factors or vulnerabilities for mental health, and what kind of signs or symptoms, so getting away from the disorders and more like what signs and symptoms kind of fall beneath these higher order, they call them spectra, and they basically kind of like shake out to be basically the 5-factor model. So you confer, each personality domain confers risk for different disorders. I mean, we talked a lot about neuroticism, but like low conscientiousness or disinhibition is a risk factor for like ADHD, for substance use, right? So you can get a lot of coverage of the different disorders. And so they're kind of working on it from the sort of, let's get rid of the DSM and like we can think about this more holistically. From a treatment side of things, yeah, I can't say I can really think of anything off the top of my head, where people are sort of developing, where I guess people other than me are like developing treatments for the higher order personality dimensions. So we haven't talked about this at all, but like one of my areas of interest is borderline personality disorder. And one of the reasons I like working with this condition is that like it's a really varied in presentation. So there's 9 DSM symptoms and you need 5 of them to get the diagnosis. So there's like 256 combinations. And when we look at data from our clinical trial, some people come in and they're high in neuroticism. Some people come in and they're high in neuroticism and low in agreeableness. Some people come in and they're high in neuroticism, low in agreeableness, low in conscientiousness. So it's sort of this like really varied presentation. And in working with these clients, I've been thinking a lot about like, well, wouldn't it be cool if we could personalize treatment such that like we could give them a personality assessment and we could say, okay, you're high in neuroticism, so you're just going to get neuroticism skills. You're high in neuroticism and low in agreeableness, so you're going to get 2 modules, right? And then maybe somebody needs all 3. And so the idea is like basically to extend it to all psychopathology. And instead of having to learn, like you said, like, 50 different manuals for all the diagnoses in the book, you have to learn 5 different treatments tied to the 5-factor model of personality. And like, we don't really care as much about the diagnosis. We care about the risk factors. And I can kind of pull from that menu of 5, a lot easier for therapists.
Yeah. So this is this new compass model that you're working on. And so going into that, you're talking, I didn't explore too much into this, but it's different modules based on tailored to individual patient care. So it's taking a little bit of the transdiagnostic approach in that you're making it accessible to therapists at a wider scale, but trying to bring in the best parts of tailored care specific for individual diagnosis. That's interesting.
Yeah. So basically the way that I, and with my team really like we started thinking about COMPASS, which loosely stands for cognitive behavioral modules for personality symptoms, loosely. The idea is that, well, I guess to start, we talked about the unified protocol treatment for neuroticism. And, when I was on my postdoc, I thought, wouldn't it be cool if we applied the UP to people with borderline personality disorder? And some people responded really well. And I was like, great, a short term treatment for BPD. And some people, like, super did not get better, maybe got worse. And when I looked at the commonalities amongst the people that didn't get better, it seemed like they were just like more impulsive, or they were sort of really low in agreeableness such that they weren't really taking responsibility for their stuff and they were blaming other people. Then I kind of went to the research on personality and borderline personality disorder and kind of saw that reflected back to me that this is a condition of neuroticism, disinhibition, and antagonism or low agreeableness. And so, but like I said, like BPD is the perfect place, like as like a researcher, to explore these concepts because it's so varied in presentation. Like if you've seen one patient with BPD, you've seen one patient with BPD. And some, like I said, some people come in with certain personality risk factors, others come in with different, like there's multiple etiological routes to get to like this presentation or this disorder. And so it seemed like the perfect place to test this concept of like skills for neuroticism, really borrowing from the unified protocol, skills for antagonism or agreeableness. We do a lot of like exposures around trust. And then skills for disinhibition, which is like kind of, we borrowed a lot of stuff from like ADHD treatment to really help people be a little bit more planful. And right now, I mean, this is pretty new. So we've just tested it in its entirety. Everybody got every module, but we're very, very likely to get a big grant from our National Institute of Mental Health to look at the personalizing based on people's personality test scores.
Why do you think BPD has such this maligned reputation? Is it because it's too overly generalized and it presents so many different ways and there's so many conflating factors that it's just hard to nail down? I think just from my own personal experience, coming at it from a layman's perspective, a lot of people that I've encountered in my life that have BPD or say they have BPD or are around people that have BPD, a lot of my projection onto them is, oh, this person's just a jerk. Oh, this person's just a narcissist. Oh, this person's just looking for attention. Does that factor into it from the judgmental side, or is there something else that's going on there that more people should know about?
Yeah. So I think BPD is really unfairly maligned. Relative. So it used to be that people thought that people with BPD like couldn't get better, right? Like, and that's sort of the prevailing notion about personality disorders, right? It's like a problem with your personality, so you're kind of stuck with it. Although now we know that personality changes over time, but that's sort of, there's not a lot of hope. I think that's like part of it. Another. But that's not true. We have really good treatments now for BPD. And what we find is that once people recover, they don't relapse with their BPD symptoms. And that's really different than something like depression, right? Where that's much more cyclical. So in that sense, like, I think there's a lot of hope for people with BPD. Again, like the condition is really varied. So sometimes BPD can present where people are acutely suicidal and they are, they need to be hospitalized frequently to like keep them safe. But most people with BPD are like kind of like functional college students that are worried about, preoccupied with relationships, anxious in relationships, anxious about abandonment. And that can look really different from person to person. It can look like a lot of reassurance seeking, or it can look like, threatening, or it can look like, I'm going to break up with you before you break up with me. And one of the reasons I really like treating people with BPD is because it's a really great place to explore the notion that people don't do things for no reason. And so, like, I love being a person that can validate, or a therapist that can validate, oh, like, when you broke up with your partner before they could hurt you, you were protecting yourself because you've been hurt in the past. And like, that is serving you to some degree, but it might be kind of an outdated reaction. So like maybe we could try something different in the future. So I don't know. Those are some stray thoughts about PPD.
How much of the uptick in push towards therapy now is sort of a consequence of people feeling like they don't have as many other people in their life to talk to? Because I feel like when you're talking through that presentation of BPD and it's just college students that are anxious about their relationship and so they break up with someone before, that to me, and not to say that this isn't, I'm trying to not, the caveat here is some people absolutely do have deeper mental health things that are triggered by past traumas or whatever it might be. But the idea that some of these lesser presenting symptoms or lesser degree symptoms, I guess is a better way of describing that. How much of that is somebody doesn't have anybody else to talk to about their relationship and they're looking for?
Yeah. So, what I have often found with patients is that it's not that they don't have anybody else in their life to talk to, it's that they're like scared to. They're scared if they like kind of like break down that wall or that they're vulnerable, that people will leave or people won't like them anymore, right? And when you've practiced that sort of like wall around yourself for a long time, it's like extremely scary to break that down. And so, I mean, that's one of the things that we work on in therapy. Like, I don't want to be your person, right? I want to help you find your people. And yeah, I mean, and to go back to kind of the start of the question, like, people, the demand for mental health care now, it's tough to kind of pinpoint what is going on. I mean, there is a huge demand for mental health care. There will never be enough therapists to meet that demand, right? And I know that really smart people are working on like stepped care models using technology to kind of meet that need. And I think like so it's really hard to say like is it because we're more comfortable talking about mental health? We talk about it all the time actually now. So people feel like more empowered to seek therapy. People talk about being in therapy way more than like even like 10 years ago. And so I think it's that like normalization that has people sort of seeking therapy. And then to your point around like that continuum of need, right? Where there's people that, really like are very depressed and are having trouble getting out of bed. And then there are people who are really distressed because they think they maybe said the wrong thing and people don't like them now, right? That feels like different, but like it's not really to the person, I think, right? And so I don't know. I think like so one of my clients that I'm working with right now, she's like 21. We had this conversation because I've been working with her for a while and she basically was like, I just feel like everyone my age should be in therapy because these are just like skills to figure out who you are, what's important to you, and like what you value, and like how to not care what other people think basically and just be you. And it's like, yeah. So I don't know. There's so many people that need therapy that really, really could use it. And there's not enough therapists. So should we not like have room in our caseloads for people that just want to kind of actualize? I don't know.
Yeah, I think looking at it from a tools and skills perspective is good. I got some supplemental insurance from my employer. I mean, it was 2 years ago when I started at this position, and just sort of in the last probably 8-9 months, explored the idea of potentially looking at getting a therapist, not because I think I need a therapist for anything, but just to have someone help me with any skills that I don't know or should know, or what you're talking about there in terms of tools being the sledgehammer that's breaking down people's walls, to give the perfect tool analogy. But yeah, so in sort of exploring that, I found that the model for care obviously is switching to a lot of telehealth, and then that's a lot more quick recurring, and it was not the model of care that I was looking at. And then I also
Mhm.
heard you mention something about the fact, and you alluded to it earlier in the conversation, but something that like if you go in search of care, there's only like a 30% chance you're actually going to find evidence-based care if you're looking in your local area, and talking to the idea of one hour after the other, not having any sort of tailored care. So it makes me rethink a little bit if I couldn't do not a better job, that's the wrong way of phrasing it, but a good enough job looking for some of the resources on my own, and potentially, like, one, leaving those resources for people that need them, and two, just being able to find the tailored resources that I'm looking for on my own versus a less than coin flip chance of finding someone who's going to be able to help me for $150 an hour. So
Yeah, yeah. I mean, I think that that's a really I mean, it's a really good point, right? I mean, one of the things that I'm working on right now is like a self-help book on personality change, and it's taking some of the stuff that we've really tested rigorously in our trials to help people work through some of that stuff on their own. I know that there's like, there's self-help like technology enhanced programs online, and some people really, really benefit from them. And other people don't because with like no person holding them accountable, they just stop doing it. That's a real problem is that like attrition or dropout is really high from like self-help programs. And we don't know if people are dropping out because they got what they needed and they're better because they weren't that severe to begin with, or if they're just like, yeah, this isn't really for me. It's not engaging enough. It's really hard to know. When people drop out of research studies, when you call them to be like, "Hey, why'd you drop out?" They typically don't respond, which is a real shame. But yeah, so I think for some people that are pretty motivated, they can get a lot from some of these more self help, and then other people really benefit from the help of a therapist. And right, it can be really hard to find somebody that is providing the appropriate skills for the person, like that it's a good match in that way.
outside of that, match with a therapist, because I have read the meta-analysis that says basically the most important thing is like your relationship with a therapist as far as like the success of therapy goes. Outside of the actual relationship that you have or would hope to have with a therapist, is there anything else that people should be looking for in terms of what they should be seeking when they go to a therapist?
Yeah. And I think when you are looking for somebody to provide you with support, to validate you, to kind of just be a touchstone to run things by, then you might not be as stringent in your screening. But like, if you are having panic attacks, if you are depressed, if you are like cannot control your worry, right? Like, you are going to want to look for somebody that's providing skill based treatment. And so when you are interviewing therapists, right, you can call people, you can email them, and there are like questions I like coach people to ask, right? So, do you provide skills? Do you talk to people about their thinking and teach them how to change their perspective? Do you do exposure, which is basically like therapy speak for like behavior? Do you push people to change their behavior? I said, do you give homework? Do you use worksheets? Do you follow manuals? Like, these are the questions that you want to ask. And like, I love that you asked that question because, like, even when I was a graduate student, like, I don't know, 15 years ago, I was like, somebody put me on the Today Show so that I can be like, the therapy that you're getting, it might not be evidence based. Here's how you can tell. And so those are the questions that I would ask.
Yeah, I think people sort of forget that, and they do this all the time as far as relationships and job interviews and everything under the sun, is they forget that they're not just along for the ride and that they have as much of a say in who their therapist is as the therapist does in providing them practice. So definitely making sure you're watching out for those things for sure. Why is it important to live in the gray?
So it's hard to live in the gray because black and white or yes or no or extremes are easier for us to wrap our head around. But like, that's not really reality, even though it's uncomfortable, right? So I guess like an example of this could be like, the person I'm dating did something to piss me off. So they suck and I'm going to break up with them because they hurt me, right? And it's like, yes, they hurt you, but they're not entirely a bad person, right? I mean, this is something that we work on a lot in therapy. Or, like, yes, you did poorly on that work assignment or that exam, but that doesn't make you entirely a stupid idiot, right? Like, there are shades of gray in between that are just like more close to the truth. And when we find ourselves being like too negative, right, then that's probably a sign that we are, jumping to conclusions, making a mountain out of a molehill, not being like really that accurate. But then I think there's a problem with being too optimistic and too positive too. Like, number one, like people don't really buy that. You can't like kind of counter I'm a loser with I'm so great, right? Because like, I mean, in my case, like patients don't really believe that. And also like it's sort of like borders on like that toxic positivity, oh, everything happens for a reason, which is really invalidating.
Are there any particular skills, either in this concept of dealing with black and white or returning to the previous conversation as far as returning to tools from therapy, that jump out at you as more relevant for someone who maybe doesn't need therapy or is thinking about going to therapy, is thinking about where they should start? What sort of tools or skills would you recommend they look into first?
Yeah. So I think the biggest skill that kind of transcends, I think, like barriers across problems is to avoid avoiding. So if you find yourself avoiding something, whether it's like asking your partner to empty the dishwasher more or avoiding applying for that promotion because you might have to do more public speaking, or you're avoiding, I don't know, like social situations because you're feeling depressed, right? Like this can like run the gamut across people and across situations. But if you notice that you're avoiding something, ask yourself why, right? Like what is the function? How is that serving you? Because it goes back to that piece around people don't do things for no reason. And so like what is that protecting you from? And often it's from an emotion that you don't want to experience. And like then you kind of ask yourself, would I rather be a person that's really good at avoiding my emotions? Or would I rather be a person that like did the thing?
I absolutely love that you just ended that with the words "do the thing," because I stumbled across this essay yesterday or the day before, and I just want to read it to you for a second. And it just says, "Preparing to do the thing isn't the thing. Scheduling time to do the thing isn't doing the thing. Making a to-do list for the thing isn't doing the thing. Telling people you're going to do the thing isn't doing the thing. Messaging friends who may or may not be doing the thing isn't doing the thing. Writing a banger tweet about how you're going to do the thing isn't doing the thing. Hating on yourself for not doing the thing isn't doing the thing. Hating other people who have done the thing isn't doing the thing. The only thing that is doing the thing is doing the thing."
Love it. Yeah. And I think like there's so much fear around like, will I fail? Will I be bad at it? Like, will it just be, is the outcome just unknown? um, that prevent us from acting. And a lot of times the fears are way worse than what actually happens, which is typically nothing, right? Like the bad outcomes typically don't happen. And so you're spending all this time and energy trying to protect yourself from feeling something uncomfortable, and you don't actually escape feeling uncomfortable because later on you're going to feel guilty for not doing the thing.
It's something to the effect of 97%, or okay, so I think it's 85% of the things that we worry about don't happen. And then of the remaining 15%, like 90 something percent of the people who did end up experiencing those things said that they were able to deal with whatever it was that they worried about with relative ease. So it's something like what it breaks down to is like 97% of the stuff that you actually worry about never comes true anyways. So the
Yeah.
purpose of you spending so much time worrying about the thing is sort of maladaptive at this point.
Yeah. And the only way that you can prove to yourself that, like, it's okay to feel, it's okay to fail, it's, that you can cope with it better than you think you can, and that bad outcomes, like, are unlikely to happen, is to actually do the thing and test your hypotheses, right? That's the only way that you can collect the data. And the more you do it, and the more you get that feedback from the world, the like less scary it will be going forward. But if you don't do it, the more you avoid, the more it reinforces that belief that the world is scary, dangerous, that the bad outcomes are likely. It like increases that perception that things are dangerous, because why else would you be avoiding it, right? That's the feedback that you're giving your brain.
So I have one final question that I like to ask all my guests, and that is, what's the last thing that you changed your mind about?
Yeah. All right. The last thing I changed my mind about was whether or not I would cook dinner tonight, because I had a really big lunch with my friends and I am still full. So I am not going to make the soup that I
I love it.
not. shattering wisdom, but that is probably the thing that I changed my mind about.
Awesome. Shannon, I love it. Thank you very much for taking the time to talk to me. If people want to find all your stuff, where can we send them?
Yeah. So I'm on Instagram at self.made.personality, or you can go to my website, personality-compass.com. And at both of those places, I give out free worksheets. If you are a listener with borderline personality disorder, you can actually download from my website, BPD Compass, and you can take it and use it with your provider until it's published. So, yeah, free resources.
I love it. Thank you very much for taking the time to speak to me today, and looking forward to all of the wonderful treatment that's coming out of the research lab.
Yeah, well, thank you so much. Thanks for having me.